Dr. Nikkiah Forbes is the director of the National HIV/AIDS Program in the Bahamas. She is the director of the National HIV/AIDS and Infectious Diseases Program at the Bahamas Ministry of Health. She is a consultant in infectious diseases at the Princess Margaret Hospital and Doctors Hospital, and she is a member of the lecturer staff at the School of Clinical Medicine and Research. She is also herself a graduate of the University DM program. And at this time, Dr. Forbes will be presenting for us today updates on COVID-19 in the pandemic and in the Bahamas and future directions. And so at this time, we welcome Dr. Nikkiah Forbes.
Thank you, Dr. Hunt-Burroughs, and thank you to the organizers for inviting me. And so tonight I will be talking about the updates on the COVID-19 pandemic in the Bahamas and where are we going with this pandemic? What is our future outlook going to be? I have no financial disclosures or conflicts of interest, and my presentation will be in two parts. In part one, I will talk about our local situation and the updates here in the Bahamas. And in the second part, I will focus in on future directions. I'm going to talk about breakthrough infections, countries where there were problems with vaccinated persons, having breakthrough infections, emerging variants, and the implications for us in our world and our country. I'm going to talk a bit about clinical COVID-19 and updates that we know about in terms of the clinical presentation and the sequelae. I'm going to update on treatment. Quite a lot has changed from since the last time we had our COVID-19 University of the West Indies School of Clinical Medicine and Research COVID Symposium. And there are some prevention updates as well. And I will also talk about what's in the pipeline in terms of research on what makes some people susceptible for COVID-19 and what might be accounting or causing some people to have asymptomatic SARS-CoV infection versus people who are critically ill. And what lessons did we learn from the pandemic here in the Bahamas? And so, as we've been hearing throughout our research week, SARS-CoV-2 is the name of the virus that caused a global pandemic that really started in December of 2019 when we first heard of this novel coronavirus, and it quickly became a global pandemic and a healthcare emergency of international concern. As of today's date, there have been 221 countries that have reported a case. And globally, as of October 27th, there have been 244.3 million cumulative lab-confirmed cases worldwide, and 4.96 million people have died of COVID-19, making this the most deadly pandemic in the last 100 years. This has actually surpassed the number of deaths from the Spanish flu in the 1900s. Nationally, the first case of COVID-19 was announced on March 15th of 2020. And to the end of the week, October 25th of this year, we have had a total of 22,306 cumulative cases. 1,157 cases are active, meaning they haven't recovered from COVID-19 yet and are still infectious. In the hospital, there are 86 cases, and the hospitalized cases are distributed between the Princess Margaret Hospital, which has the majority of the hospitalizations at just over 50%, followed by Doctors Hospital across both campuses, the Rand Memorial Hospital and the South Beach Health Center, which was repurposed for a COVID care site. There have been 643 cumulative deaths to date, and the last percentage positivity rate at the end of the last epidemiological week that ended October 25th was 15%. So what is the situation around the Family Islands as it relates to the COVID-19 cases? In this table, you will see the total confirmed cases in terms of the cumulative count by island. And you will see that New Providence makes up 76.3% of those cases, followed by Grand Bahama with 11.3%. And then you can see that throughout the other family islands, there have been reports of cases, with Abaco and Eleuthera having roughly around 650 cases. And there have also been clusters of COVID-19 cases in various family islands at various times, including Bimini, Crooked Island recently, and the other islands. The map of the Bahamas shows the active COVID-19 cases at the end of October 23rd. And you'll see that there were about 1,069 in Nassau and 48 in Grand Bahama. Eleuthera had 45 cases, and those were the islands with the top 3 number of cases. And there are other islands who have single digits, including Inagua, which came out of a cluster, which had 5 active cases at the end of the last epidemiological week. So here in this graph, we can see the number of incident and cumulative COVID-19 cases by specimen collection date, as per the Bahamas Ministry of Health. And this shows the cases from since the start of the outbreak. So please note that the first wave was quite small now in retrospect. And that started in March of 2020. And that there was a decline in these cases to a very low baseline. One day there was only 1 case, and that wave indeed ended. Then we had a second larger wave that started in July of 2020. And you can see that that wave also had a sustained decrease over a number of weeks. That stayed relatively constant until the third wave began here in about March of 2021. Now, if you will note, there has been no sustained decrease over weeks in this third wave. And so the third wave is indeed actually continuing. And there were ebbs and flows in this third wave, that there was a low point here, but cases again surged, and they are now starting to decline again, fortunately. So it is possible to take the epidemiological curve and overlay certain things. It's possible to overlay significant things that may have happened, and also restrictions and interventions that may have been put in place in an effort to flatten the curve. And so this is what this graphic shows. So here is the epidemiological curve that we just looked at. And as you can see here in the orange, I've overlaid some key things that may have happened. And so we had border reopening right about here at what is called epidemiological week 23. That correlates to about July 1st. And then a summer period where there is a series of a number of holidays and weekends. You will also see that in the time period that we had the first wave in March, immediately that first week, we had a 24-hour curfew. And as a matter of fact, Dr. Thompson showed a picture of no cars being on the street, and only essential staff were allowed to leave home. There were also travel restrictions and border closure, virtual school, and there was a government quarantine facility and isolation facility. And that may have caused this wave to be flattened significantly with a sustained decrease in the number of cases. In the summer period, there is a cluster of holidays, and we did not have a 24-hour curfew in the second wave, but we did have night restrictions and enhanced crowd mitigation. That may have contributed to the decline in the second wave. This is when the vaccines rolled out. Now, keep in mind, it takes time for a large proportion of the population to develop immunity, but that is the date that the vaccines rolled out. We also found here that it was announced that circulating strains of variant COVID-19 were identified in the Bahamas with a Delta predominance, but all the other strains that were sampled were also variant strains that are more infectious. And that happened in this period here. And again, we went into the summer travel holiday period, and there was an attempt to have earlier night restrictions. And then this is the period that was the polling day, and the dissolution of Parliament was around here. And so you can look at the epidemiological curve and try and analyze it and see if any interventions made any sort of a difference, or were there any key notable things that may have impacted these waves. As we know, the socialization and poor public health compliance may impact and increase the spike of COVID-19 in country. And it certainly gets harder when there's a lot of COVID-19 in the community and community spread. This is the breakdown of the COVID-19 cases by sex at birth. And we can see that in terms of the cumulative cases, females made up 53% of the cumulative cases and males made up 47%. And then when we looked at the case distribution by waves, that was almost 50-50. Well, females made up 51% of the cases in wave 1 and in wave 2 as well. And they account for 55% of the cases in wave 3. This is the age distribution of the cumulative COVID-19 cases. And please note that the majority of cases are in the age group 30 to 39 years of age, followed by 20 to 29 years of age and 40 to 49 years of age. And certainly there are fewer pediatric cases. The curve of deaths really does follow the epidemic curve in this virus. And so you can see the waves of COVID-19 here on this slide as per the WHO, with waves 1, 2, and 3. And you will see that wave 3 has been the deadliest wave, with the majority of deaths occurring when indeed there was the highest spike and surges of COVID-19 in country. When we look at the distribution of deaths by sex and age group, females make up about just about 50.5% of the deaths, and males 49.5%. And when we look at the age distribution of those that have died, the majority of cases are in the 40 to 64-year-old age group, followed by the over 65 age group. So where are we in terms of vaccinations in the Bahamas? We rolled out vaccinations. The pilot actually started on March 16th. And to the date of October 16th, roughly 32% of the population have received 1 dose of the COVID-19 vaccine. And about 30% of the population are fully vaccinated. And so 1 or 2 doses of the vaccine were given in the recommended interval for those 2-dose vaccines. And perhaps this was the correct decision, because we know that having only 1 dose does make persons at risk for having breakthrough infections. And we have recently received a delivery of the Pfizer vaccine so that more persons will be able to be vaccinated. And we have heard, and we thought it very, very important to have local data that would reflect our experience with COVID-19 hospitalizations and what was the vaccination status and deaths among persons that were admitted with severe COVID and whom had died, to have a local experience to correlate with what was happening and what was being reported in international spaces. And so we have heard that 95% of hospitalizations and deaths were unvaccinated persons, with a smaller percent, between 2 to 3%, being partially vaccinated, and 1 to 2% are just over being fully vaccinated. And where are we in terms of the world statistics with vaccination? About half of the world has had 1 vaccine or more, and 39% are fully vaccinated as of this morning. Well, we know that variants can make vaccines somewhat less effective compared to the original strain. And so we do know that there are variants in country, and the Bahamas Ministry of Health, the reference lab, reported on a select sample of patients that had been sampled between May 6th and August 8th in the Bahamas. And this is what was found. Of those samples, and 81 were analyzed, 51% of those samples were positive for the Delta strain of COVID. and 48% were the alpha strain, and 1% were the gamma strain. What does that mean? All of those are variant strains of COVID-19, and they're all so-called variants of concern. So when it comes to the genetic lineages of SARS-CoV-2 that are emerging and circulating, there's a classification that there are various terms: variants of concern, variants of interest, variants of particular interest. But a variant of concern is worse for treatments, vaccines. They may be more transmissible. They may also be more transmissible at even a faster rate. And alpha, beta, delta, and gamma are examples of those variants. So delta is twice as transmittable as other variants. Antibodies and vaccines are less effective. Alpha is more transmittable, and gamma, the vaccines, are less effective. And currently at this time, the National Reference Lab sends out those samples for phylogenetic and genetic testing. So that is where we are in terms of the update of COVID-19 here in our Bahamas. And I'm going to now move into part 2 of our presentation, which is what does the pandemic future look like for COVID-19 in the Bahamas and indeed worldwide. So this is what the world's epidemiological curve looks like. And you can see that it also has waves. And at this point, if you know that there are 242 million cumulative cases and many more active cases and cases per day, that what is your strategy? Can you eliminate COVID-19? It's highly unlikely, and countries have tried. So for example, New Zealand did try to eliminate COVID-19, and they did very well for some time. There was 0 cases. They really enjoyed many freedoms. However, what becomes clear is that when you do have reopening, that COVID-19 will resurge. And that's exactly what's been happening in New Zealand recently. And so there's a lesson here in that COVID-19, that elimination is highly unlikely. This is not the only virus of its kind. SARS coronavirus, the first one, and MERS coronavirus were also coronaviruses that were novel at those times, 2003 and 2012 respectively. But they were eliminated. They were eliminated from the planet. They maybe were not as fit, but it appears as if COVID-19 will be here for some time and that it will indeed be seasonal. In the context of vaccinations, 3.86 billion people have received a dose of a COVID vaccine, but that means that many people are still unvaccinated, almost 50%, and that means that they are at risk. And that also means that there is a risk for emerging variants. And at this time, there's a variant that has been identified in about 53 countries called the Delta Plus, Delta AY2. And it does appear that it may be more transmittable, but it is being studied. It's not really circulating in any large scale at this time. And so scientists are studying that. And so we do have to be concerned that with the epidemic still happening, that that is fertile ground for variant emergence. Other strategies. So is the strategy instead better if you look at protecting the health services? And the key then would be putting in place mitigating steps to keep the cases low and below the capacity of the health system so that there isn't too much pressure to the health system, so that COVID care can be delivered to save lives and in order to prevent the diversion of services away from usual care. And as Dr. Thompson alluded to, that means that usual care, cancer care, and chronic non-communicable diseases may not be getting the attention. And so there are already consequences from that. And then there's disease control. There have to be modalities to be put into place to mitigate severe COVID-19 and deaths, and that is going to get to be critically important. So that's exactly what the future is going to look like. Elimination, highly unlikely, and how do you put in place strategies and strengthen your available services like contact tracing, testing, early testing, and other interventions to try and give us a chance with this epidemic. I'm going to talk now about breakthrough infections. And this is really a hot topic because we hear every day, and there's a lot of information that there can be breakthrough infections. And there have also been reports of countries that are seeing breakthrough infections and high numbers of COVID-19 infections, including in people who have been vaccinated. And this has to be understood and scientifically studied and analyzed so that we can learn lessons from this. And without doing this, it does create opportunities for misinformation, further mistrust, and this thing called COVID pessimism, which is now a new term, where people are convinced that COVID is not going to go away and that there isn't going to be viable solutions. And so I'm going to spend the next part of the presentation talking about some of these things that have happened and how we should interpret it and the lessons that we should learn from it, and what does this mean for our future outlook. And so one such report was in the Morbidity and Mortality Weekly Report. And this reported an outbreak of SARS-CoV-2 infections, including breakthrough infections in people who had been vaccinated associated with large public health gatherings. And this was in Massachusetts in July of 2021. And essentially, there were 469 cases of COVID-19. It's apparently a huge summer weekend where there are a lot of parties and gatherings and reunions. And in this community, vaccine coverage was actually about 69%. However, there was an outbreak associated with this weekend and these events, and approximately 74% of those cases occurred in fully vaccinated persons. And when they looked at the genetics of the viral strain, 89% were the Delta virus and 1% was Delta plus. Now, 79% of the vaccinated persons who got COVID were symptomatic, and 5 persons were hospitalized, and 4 of those persons were fully vaccinated. There were no deaths reported. And this was really the first large outbreak like this that was reported in the United States. And it made people ask, just what is happening here and what was the recommendations and take home. And so it became clear that even if you were vaccinated, if you're not following the public health precautions, if there are indoor gatherings, for example, and a mix of persons, including persons who've recently traveled, vaccinated and unvaccinated, there is a potential for COVID to spread. And so the recommendation from the CDC MMWR was that all persons, even the fully vaccinated, should wear masks indoors and in public settings, especially in areas where COVID-19 transmission risk is high or substantial. And it even further suggested that in jurisdictions without substantial or high COVID transmission, consider expanding prevention strategies, such as good adherence to mask wearing and other public health measures, such as mitigating large gatherings. So that is what happened there in that case. And then we hear a lot about Israel and the fact that Israel was very, very quick out of the gate to start their vaccination strategy and to get a number of persons vaccinated and have good vaccine coverage. However, there became a report that persons who were vaccinated were indeed having breakthrough infections. And so let's talk a bit about that. So 80% of eligible citizens were vaccinated very early in the summer, June of 2021. And when we say eligible citizens, at that time, it was persons who were 16 years of age and above. That made up about 68% of the total population. What happened was that the country then lifted movement restrictions and mask mandates, and it went very much back to normal pre-COVID movement and behavior. The Delta variant arrived in June of 2021, and then COVID case numbers started to climb in September of 2021. And then it was noted that about 60% of hospital admissions in mid-August had 2 doses of the Pfizer vaccine. But this had to be studied and looked into closer. And so there was a sub-analysis of this. And so what they did was they looked at vaccine efficacy and they broke it up into certain things like people who had medical comorbidities and age groups and a vaccine period. And that's what's reflected here in this graph. And so they looked at, this is the over 65 age group. This is 42. This is the over 60 age group. This is 40 to 59. This is below that age. This is the younger age group. And this is when vaccines rolled out. And so just like here, the vaccines had been prioritized to those that were most vulnerable, people with medical conditions and older people at first. And that's what this black bar is here. So those over 60 got the vaccines first. And so you'll see that there are no persons who were able to get vaccines here. That's why these bars are actually essentially white, because they weren't eligible at that time. But as time went on, you will see that the persons who got the vaccines first over a 5-month period were more likely to present to the hospital having been fully vaccinated with breakthrough cases. And that was less likely in those who got the vaccine later, like 2 months prior to the study date, for example. And this did not bear out in the younger age groups. And so that made them interpret the data as the persons who are 60 years and older, especially those with comorbidities, are more likely to have breakthrough infections and end up being hospitalized and dying, hence the recommendation to put in the booster in Israel. And that does support the booster for the Pfizer vaccine in any event. So it actually does support that when you look at the age-adjusted numbers for vaccination, the chance of hospitalization for those greater than 60 years reduced 40-fold if you're vaccinated compared to unvaccinated, however. But they did implement a booster program, and that does appear to be bearing fruit, because just last week they reported a very, very low COVID-19 positivity rate of below 1% for the first time ever, and a reduction in hospitalizations. And so as a follow-up, there is this study in the New England Journal of Medicine that suggests that fully vaccinated persons 16 years of age or older, at least 12 days after the booster, their rate of infection was lower in the booster group than the non-booster group by a factor of 11.3, and the rate of severe illness was lower by a factor of 19.5 in the Israel studies related to COVID-19. Now that's Pfizer, but what about the AstraZeneca experience? So Public Health England also has a publication that looks at the protection against hospitalization, and it's much higher and holds up well, although there are some signs of waning with AstraZeneca and Pfizer for the elderly. So you can see here that over time, when we look at the antibody levels, they're declining somewhat, especially over age 80. It's also going down a bit here to about 80%, and somewhat less for younger persons. This is also true in those who have underlying health conditions. So you can see here that there's waning, and that would make persons clinically extremely vulnerable if the efficacy, this is the AstraZeneca vaccine, would fall to about 60%, or even about, this is about 70%, but you can see that that's less pronounced in the younger age group. And the protection from death holds up well for both vaccines and across age groups from young to old. Now, what does this mean? It is safe to get a booster dose, but it is still being medically looked at. And the data is still out in terms of AstraZeneca and Moderna. There's a half-strength dose. Johnson & Johnson, there is going to be a booster dose for that about 2 months after getting the first dose, which may imply that that should have been a 2-dose vaccine. And those are things that are in the pipeline. So vaccines, what may it look like? They may be changing over time. Additional booster doses may need to be given, and something about the vaccines and the coverage for variants may change over time. Also, the way that vaccines are given, we can expect that to change in the future. Some will continue to be intramuscular, but there may be other modes of delivery. For example, nasal vaccines. There's a study that will support that mucosal immunity may be better with the nasal vaccines. And so it may somewhat protect you better in terms of inhalation of droplets, for example, if you're exposed to COVID-19. Now, the CDC has a very, very large study where they're looking at the breakthrough experience, and of more than 189 million people who received the COVID-19 vaccine in the United States. They have looked at the reported breakthroughs. That accounts for about 41,000 cases, which is very, very uncommon. The rate of having a breakthrough infection would actually be way less than 1%, about 0.02%. But this is ongoing and will continue to be done. We're in the process of gathering that data for the Bahamas. The CDC has a compilation of studies that they released on September 10th, and that summarized that for persons who are unvaccinated face much greater risks from COVID-19 than vaccinated persons. They're 4.5 times more likely to become infected, 10.5 times more likely to be hospitalized, and 11 times more likely to die of COVID-19. And in the United Kingdom, the risk of breakthrough infections in this study by Antonelli and et al. Indicated the risk of breakthrough infection was 0.02%, and the risk of long COVID-19 was 50% lower than unvaccinated persons. I'm going to move on now to the future and what does clinical COVID look like? Well, we've come a long way in terms of knowing about this new virus, and there are a number of sequelae that can happen. People can get myocarditis, pulmonary fibrosis, diabetes can be unmasked. They can actually present with debut diabetes mellitus. There can even be fungal infections. But there is a sequelae that is called long COVID or post-COVID-19 or Longhauler Syndrome. And there's a definition for this. It's new, returning, or ongoing health problems that people can experience 4 or more weeks after first being infected with the virus that causes COVID-19, as per the CDC definition. And this actually makes up to 30% of persons after COVID. They can complain of this problem. It's not a small problem. It's turning out to be quite large. Almost 1/3 of people who get COVID may end up having long COVID. The pathophysiology is being studied, but there are a lot of postulations. It could be direct viral toxicity, endothelial damage, the immune system is dysregulated, a hyperinflammatory state, or sequelae of critical illness, but there's a myriad of symptoms. And some of them are very, very vague. They can include tachycardia, confusion, memory loss, fatigue, something called brain fog, cognitive dysfunction, worsening of psychiatric conditions, anxiety and depression, breathlessness, feeling feverish, for example. And these symptoms can change over time, and the recovery time varies. And it's also very frustrating for patients because a lot of people do not believe that they're actually feeling these things and discard it. And so it has been recognized in the infectious disease world that people will be dissatisfied and feel marginalized and minimized when they present with these symptoms, but they really do feel unwell. There's no diagnostic test to say that this is what they're having. It's guided by symptoms, and there's imaging and other tests like pulmonary function tests, cardiac tilt table testing, etc., that is guided as per specialist recommendations. And there's no cure for it yet. It is actually a patient-centered holistic approach that's going to need treatment partnerships, and functional improvements may help with that multi-specialty addressing of this condition. And vaccination may help in up to 50%, but these patients are going to need support. And so in our future outlook, we're going to have to build and expand programs to be able to support such patients. And we're also discussing that. I don't have much time left, but since our last research day, there have been some updates on therapeutics. So the last time we spoke, we basically had corticosteroids and an antiviral called remdesivir. But there are some new kids on the block. For example, the IL-6 antagonists that are repurposed rheumatoid arthritis drugs they seem to be helpful. There's a trend to reducing mortality, and also patients do seem to have greater clinical improvement at 28 days when they are on some of these medicines. And then we also have neutralizing antibodies that were not available the last time we had our COVID symposium. And they have two roles. They can be for post-exposure prophylaxis in people who are at high risk for getting severe COVID and they have been exposed, they're COVID negative, meaning, or they can be used for ambulatory care patients who already have COVID-19, but are at high risk for decompensating. And so there's some criteria for that, essentially. So for prophylaxis, it largely is for people who have a pre-existing medical problem that would put them at risk. And it can be helpful for those not fully vaccinated, but that's not absolute, because there are people who are fully vaccinated that will not mount an immune response. For example, persons with malignancies or on immunosuppressive medications. So of the persons who received this drug, which is actually Regeneron, that's the trade name for it, there was a reduction, a relative risk reduction by 81% in those people who received this drug for post-exposure prophylaxis. It also can be given for treatment, but that's for ambulatory patients with mild to moderate disease who are at high risk for severe disease. And the criteria for who's at high risk are those who are older age, for example, more than 65, obese or overweight, pregnancy, chronic kidney disease, diabetes, immunosuppressive therapy, cardiovascular disease, sickle cell disease, neurodevelopmental disorders, for example. And this may help significantly. There was an absolute mortality reduction of 1.9% and no deaths seen in the study arm compared to placebo, and a lower relative risk of hospitalizations and a faster clearance of viral load, essentially. Now, what's to know about this? This is not a substitute for vaccination. It's better to not get COVID in the first place. And when we think about the global public health good, vaccinations are free and safe and effective and very available versus this therapy, which is about $3,000 a vial. So it's not really a good viable comparison. In the pipeline, there are other medicines that are being studied. For example, a drug called Malnuparavir. It's an oral antiviral treatment for COVID-19, and it's very promising. It's in phase 3 trials, and essentially it is for eligible outpatients who have SARS-CoV-2 infection. And if you take this within 7 days, and it's administered twice daily for 5 days, at day 5, there was increased viral clearance in all of the patients, and the risk of hospitalization and death was cut by 50%. And so it is still being studied, but if it does become available, it definitely will change the game for persons who have COVID. And the great thing about this is it will be able to be produced at a very, very cost-effective price. And the manufacturers have already promised that the patent will be shared, and there's already mechanisms being developed for how this is going to be able to be manufactured and shared as a global public health good. My last slide in terms of our future outlook is the genetic basis of coronavirus disease. And when I started out, some people are asymptomatic, other people die from COVID. And there are a number of things that may be contributing to that. Gender, blood group, HLA, genetics, ethnic groups, geographic backgrounds, we don't know. And so there is a movement to understand the causal relationships between host genetic basis and COVID-19, and to see if there are biomarkers for individuals at high risk. And that would then drive potential targets for therapy, a drug curative effect, identify at-risk persons, and effectively control disease. And so there are large data consortiums that are organizing to study this, and we hope to be involved in such research. So we will update you on that as it progresses. So what did we learn? What's the way forward? What's the future outlook? COVID-19, it's not likely to be eliminated or eradicated. Strategies need to protect the health system and prevent surges in cases and to prevent deaths. Vaccines are effective to reduce infections, hospitalizations, and deaths. Breakthrough infections may occur. And it's critically important to combine vaccination strategies and following public health measures, especially universal mask wearing in public places and indoors. Variants are a threat and will continue to emerge, especially in the context of insufficient vaccination coverage. And as time emerges, in the pandemic outlook, more is becoming known about manifestations of the disease, including long COVID. The treatment options have increased with clinical trials on newer antivirals, reporting promising results. And more is to be learned as it relates to mechanisms of disease severity and genetics. However, research does thrive in the COVID-19 pandemic in the Bahamas. Thank you for asking me to share this presentation with you, and we look forward to sharing more of our work in terms of the outbreak here in the Bahamas. Thank you.
Dr. Forbes, thank you for a very informative and comprehensive and interesting presentation. You always seem to find a way to help us to distill a whole lot of information in ways that we can make it useful. And so we want to thank you. I really appreciate what you've done in this amount of time with so much information. Do we have any questions at this time for Dr. Forbes? Dr. Cooper, I see that your hand is raised.
Hi, good evening. Can you hear me?
Yes.
Excellent presentation, Dr. Forbes, as usual. The CDC website recommends a booster shot in people 50 to 64 years old that have medical conditions. And some of those conditions are diabetes, cardiovascular disease, including hypertension and obesity with a BMI greater than 25. There's the Bahamas and 10, which is probably half of our population in that age group. Do we intend to offer booster shots to that population as recommended by the CDC?
That's a great question. And yes, we're going to have to do that at the right point. But there is an ethical dilemma, and I always try and remember fairness as it relates to accessibility to healthcare and doing the best for all, essentially, and healthcare for all. And so in our context, we don't have an unlimited quantity of vaccines at this time. And indeed, only 32% of our population has been vaccinated. And so there are other conversations. For example, the WHO has pointed out that even when we look at vaccines as a global public health good, half of the world has not been vaccinated. And that when we think about giving boosters, is it fair to boost when there are vulnerable people, some of them in frontline positions that have not received the vaccine to date? And there's a little more to it, because we know that COVID, it's still a global pandemic, and that in that context, variants are happening, and variants break through existing vaccines. And would it not be a strategy to get a dose of vaccine to everybody would cut down COVID significantly, hence maybe needing less boosters or new vaccines, you see? So it is a little bit of a complicated issue. Now, there are people who are super immune to COVID. I couldn't talk about everything in the time frame. If you had COVID and had a vaccine, you're super immune, apparently. And so we have to weigh that in terms of when they can be introduced. Yes, we're going to see that happen, but we have to strategically plan it so that there's sufficient vaccination coverage so that it's fair first. And I would say to you that of all the countries in the world, this is still somewhat an experiment, and countries are still having to decide for themselves. For example, there were countries that of the doses they had, they decided to give everybody one dose, versus we didn't do that. We gave the 2-dose series as soon as possible when you're eligible. And what does that mean, right? Because in partially vaccinated persons, there's some protection, but not as much as we saw in our data slide with the vaccination experience, that partially vaccinated persons are also vulnerable. And so it is a little difficult to navigate, but to answer your question as simply as possible, yes, I think we'll get to the point where we're giving boosters, especially to vulnerable persons. But there probably will be a little time before then, because we need to increase vaccination coverage somewhat before then.
Thank you. Dr. Roberts, then Dr. Thompson, and then Dr. Barrett.
Good night. Excellent presentation. A great overview. Compliments to you, Dr. Forbes. I noted, though, in your talk, you didn't mention much about herd immunity. Can one make the case that in the Bahamas, noting the fact that we are decreasing the number of new cases that we see and decreasing our hospitalization, can one make the case that what we have is as many more people are being vaccinated, and the fact that we have a high prevalence of COVID-19 in the community, could we then say that the combination of the high prevalence, people being infected asymptomatically, and the vaccine, that what we actually seeing now are decrease in cases being herd immunity?
That's a great question, Dr. Roberts. So here's the principle. Let's start with the principle of herd immunity. That's the percentage whereby expert consensus says if you have that amount of your population immune, you won't be in clear and present danger. Basically, there'll be so little COVID, so little people that COVID could actually infect. But that's actually about 80%, 70 to 80%. So we're a ways off from there. Even if you add the people who got COVID that were lab confirmed to the number that were fully immunized, we would still be quite a ways away from that statistic. Some people think that herd immunity, that 80% number, is going to be extremely hard to achieve for the world. Given vaccine hesitancy, pessimism, and newer variants, that is starting to get to be a destination that is harder to reach than we thought. But there are things that are contributing to the cases going down. And I could go back to the epidemiological curve, but a part of that is vaccinations. And a part of that is us coming out of the surge that we had and other factors that related to that surge. And overall, with an increased number of persons being vaccinated, there are less people that are susceptible. So I think that is starting to bear out. But herd immunity, we're gonna have to see. We'll have to see if we can get there, if the world can get there.
Thank you. Dr. Thompson?
I wanted to add to the conversation around vaccine equity. And so as we see the larger countries or the wealthier countries giving boosters, it now presents a challenge for smaller countries like us or those with less resources, because if you recall, there's a lot of us that benefited from donations. And so as the larger countries began introducing their booster, the availability or the supplies will be less available for us to get donations. And so adding to Dr. Forbes' conversation or her response, we can find ourselves, the rest of the world can find themselves in more jeopardy, because the access to the vaccines will dwindle as the larger countries continue to push towards boosters. So that's just a thought for the group to keep in mind. Good night.
I expected an excellent presentation this evening, and I was nowhere near disappointed. It was really, as you said, Dr. Hunt Burroughs, just really what we needed. I see that Dr. Bassett and I are thinking the same thing. So Dr. Bassett, if you would permit me, I'll ask the question for you. What about the children? Is that even on the radar screen for us in light of all that you have said? And the second thing is just a comment that it looks like this disease is actually involving every specialty. And now there is, what did you call it? COVID, this and psychiatry's, it looks like it will be inviting psychiatry to come in to join the team as well. And I know that psychiatry is actually residents are doing several research projects related. That's why you can look forward to next year's research day when all of those get presented. But just what's it with the children? And you can ignore my last comment, but let's see if I'm right with time.
So vaccines, Pfizer is having an EUA, and the eligible population is going to be younger, 5 to 11 years of age. And I think that is actually rolling out in the US this week. And so what is the information? It's that children can get COVID. They could spread COVID. Some of them, sadly, some children will even die from COVID. We don't know why some do fine and some die, because healthy children can die from COVID too. And we need to try and figure that out, really, why some people are fine and some people are not fine. It seems overall from the global experience that if a child gets COVID, they seem to be okay and be able to recover. As you saw when I presented the number of cases and the deaths, that it was low in the pediatric group. But there's a little more to it than that, because children can get COVID and they can spread it. And what I didn't present in my presentation is that there's an economic and health fallout from COVID, an economic and social and education fallout is what I meant to say. And that the Minister of Education said in the media this week that 30% of children are not in school or not accessing school here in the Bahamas. And so when they go back to school face to face, which is needed, there can be COVID. And there were spikes when school opened in August in the US in children. And there were some other school COVID studies that suggested that the adolescent group too, because of their activities after school, that there could be a spike in COVID cases, and then they can spread it to vulnerable people like teachers, parents, grandparents, and so on. And so that it could be good to vaccinate, because it will add to the pool of less people who are vulnerable and able to spread COVID. I would think that is reasonable, that those points are reasonable to support vaccination in that age group.
Dr. Forbes, brilliant and thorough presentation. In relation to the reality of mutation of all viruses, we know that viruses actually can mutate within hours. So you can have different strains in one person over a period of hours. Is it possible that SARS-CoV-2 can mutate itself into neutrality?
So COVID mutates like any other virus.
Right.
And when it makes a mistake, that's what it is. It makes a replication mistake. When it does that, that sometimes confers nothing. Sometimes it doesn't confer disease, it doesn't confer resistance, it doesn't confer transmissibility, but sometimes it does. So that's the problem. Right. Yeah. And so I didn't want to take too much time in the presentation, because it was so hard to try and highlight what future outlooks I would talk about. But there are other variants. There are variants of interest that the scientists look and say, oh, this could be something that's important. It could really be harder to treat. And then there are variants that are no consequence at all. They don't do anything bad.
Thank you. May I add to the comment about psychiatry that Dr. Frankson made? Please, Dr. Burrs?
Yes, please.
Okay. From the very beginning, psychiatry was involved, and we're seeing more now. Dr. Forbes mentioned about fog, and related to something called alien cells. But we have seen all the variety of psychiatric sequelae in COVID patients. I've treated quite a few myself, and it is estimated, according to research, that 20% of people who got infected with COVID-19 are going to have some significant psychiatric sequelae. So psychiatry should be at the table right now.
Amen.
Thank you, Dr. Barrett. Dr. Forbes, there is a question in the chat that asks, with regard to vaccines, if an individual has had the first dose of the AstraZeneca vaccine and the second dose of Pfizer vaccine, would that individual be considered fully vaccinated? And would you recommend a second dose of either vaccine as a booster?
Yes, that person would be considered fully vaccinated. And there are studies that suggest that with the mixing of vaccines, that the immunity might be better in terms of the antibody level that could be measured. And if they were going to get a booster, then they could get another vaccine. They could get either one of those other vaccines. However, the data is not quite in yet on AstraZeneca and when that booster will need to be. It's being studied. But Pfizer, there's already a clear indication, at least in the United States, and it is being boosted already in Israel.
Thank you. I see Dr. Philippe, your hand is raised.
Yeah, thank you so much, Dr. Forbes. That was definitely an amazing learning experience. Excellent. I wanted to talk about the Longhaul Covid, and you mentioned the sequelae of the brain fog. Two questions. One, has that been seen in young people and young adults? And two, recognizing the long haul, how do you think it's going to transform the public health service and system? Because as you know, right now, people, you're saying that clients will come in and describe this, and now as a public health physician, you have to determine, did they have COVID? Is this real? How much time to give them? And how will this impact the productivity of the public health service? What policies do we need to start to put in place? How do we need to really change the way we are providing the service, recognizing that this will make a significant impact?
Yeah, that's a great question. So we have to put in place systems to care for these patients, and it has to be multi-sectorial. And there has to be a way of screening these patients, and it's great that it has a definition. Because even acute COVID, a week or two afterward, people can still have a lot of those symptoms: breathlessness, feeling tired, that they can't think, fatigue. Some patients can't even get out of bed. And so we have to provide the support mechanisms. And how this is shaping up is long haul clinics in some places. And there are actually studies going on, like in Washington, DC, there's some studies on long haul, and people have already put in place support services. But like I said, it has to be multi-specialty, and it has to involve psychiatry, ID, public health, internal medicine, pulmonology, cardiology. It really depends a lot on the symptomatology the patient has, and more support, psychology, occupational health, could be physiotherapy. It really, really depends on what symptoms the patient is feeling. But a word of caution here: some of these symptoms are vague. Like they can have something like the POTS syndrome, where they just feel tachycardia, lethargy, weakness when they stand, for example. And it's more common in females, and especially highly functional individuals, in one study in Washington, DC. And people were reporting dissatisfaction because when they reported having these symptoms, people didn't believe it. They didn't think that there's nothing objectifiable. There's no test or anything. And so we do, and it can happen in up to 30% of patients who get COVID. So we do need to put support mechanisms in place. We're going to have to think that through, because there are going to be a lot of people who are affected with this, and the recovery time can vary. Some of these patients can have this for months, 10 months, 8 months. Vaccination can help. It can reduce symptoms, and 50% of patients, their symptoms improve significantly or go away after vaccination.
Dr. Forbes, question for you. For those individuals who would not have been previously vaccinated prior to having the natural infection, any comments on how many doses of the vaccine they should receive?
I'm still in the standard dosing regimen, but it's just that people who did get COVID are super immune, but the recommendation is don't try and get COVID and then get vaccinated. It's still in the usual vaccine series. There are some people though, right, that won't mount measurable response. Not that you're supposed to try and measure a response, but think of someone with a blood cancer, for example, or on chemotherapy, for example. They may not actually become immune after vaccination. So that's where you need to start thinking about boosters and so on.
These are some of the questions that people ask. So I see 2 hands raised, and these will be the final questions before we bring the session to a close. Dr. Moxie, and then Dr. Van Turen.
Yes, good evening, everyone. Great talk, Dr. Forbes. My question is a straightforward one. It's on the J&J vaccine. Are there any plans to have the second booster given? And why I'm asking that, how would you prepare the public for that? Because they're going to say, see, they don't know what they're doing again. They said we only needed 1, and now they're saying we need 2. I'm just talking in the colloquial Bahamian, you know, because there's so much, you know, mixed messaging going on out there that, first of all, are we going to have it, or are we going to give it? And then how are you going to get around the messaging to convince people who thought they were just going to need 1 shot to come back for their second shot?
Yeah, that's a great question. So first, let me say that COVID-19 is a new virus. And so the only way to know about it is to study it and have objective data. And that's what actually the largest compilation of scientific data and active scientific research is going on right now for this very same virus. It's never happened like this before. So there is a lot of data in the searchable space. And that's how we have to look at this. We have to be objective and say, okay, we had vaccinations that was supposed to help significantly. We're seeing that there can be breakthroughs. We're seeing the need for boosters, but you have to try very hard to communicate objectively and from a place of understanding. So in new outbreak viruses, the human condition is we blame people, we have mistrust, we have disbelief, and false information. That is just the way it is. And we're called as doctors to get to know the facts and to study the experience to say, what do we make of this? What does this mean? How do we regroup? Is there a lesson that we can learn here? And for example, Israel, we when we studied it, we realized, okay, several things. You can't discard the public health measures with vaccination. You need good mask wearing. And who got in the hospital? 65-year-olds, some period out from when they got their vaccine. And so hence the recommendation came, do not forget about the public health measures. Everyone has to be adherent to mask wearing, and boosters may be needed for vulnerable people. And so you just have to try to humbly understand where people come from, because there is a reason for vaccine hesitancy, mistrust. It's deep rooted. And there was injustice that happened in healthcare systems and studies and other things. That really happened. It wasn't unfounded. And you just have to speak the facts and study it. Johnson & Johnson, it's not in practice yet that we're going to need a second dose. It's looking so. The CDC and the FDA are discussing that. Johnson & Johnson, quite probably the US has the highest number of people with it. And so it's being studied. You know, it didn't roll out until, you know, just the end of last year, was it? And so we have to see what will be the experience. And, you know, they're looking at, for example, the curve of patients that are presenting who got what vaccine. And so when you have new scientific information, you pivot and you, I hate that word, but, you know, that's what you have to do. You have to incorporate updated data to update the science. And that's all you can do when you try to just present it neutrally. Now, in the face of that, you're going to experience hesitancy and vaccine and COVID pessimism. And that's not a term I made up. That's actually a real term. That people want this pandemic to be over. They want to go back to the way it was before. They don't want to hear anything else about COVID. That's actually being studied. So you just have to keep trying to wear away at it.
Okay, we are at the limits of time. Last question, Dr. Van Turen.
Hello, can you hear me?
Hi, Dr.
Yes, we
Bantu.
can.
Oh, because I'm calling from London, and I was very keen to hear all the questions. Unfortunately, the time difference, I missed a lot of your lecture, your talk earlier on. Anyway, there was mention about the long COVID or long haulers. And I think quite a while back, I might have seen one or two, but I'm seeing more and more recently. Obviously, Dr. Forbes, there's no specific answer to that from what you are answering the question earlier on. In fact, I was watching a TV program here last week after another conference from Nassau by Francis. And straight away, I saw this program about long haulers, and it's becoming quite I think they're doing a lot of work on it. In fact, they have a sort of a society or what you call group, and then it's become bigger and bigger. And then I saw some coming from the States as well, that in England, there's about over 1 million long haulers, but I think there's even much more than that. And their most common complaint I hear from all the people talking about it, who interview long haulers, is fatigue, brain fog, and they still haven't got any way of dealing with it. Have you heard any way they're dealing with that to begin with?
Yeah, that's exactly the challenge with long haulers. There's no cure for it. It's not like you can take a course of antibiotics and then it's over. So how it's dealt with is a multi-sectoral team and specialist driven. If the patient has something like a POT syndrome, the cardiologist, if they're cancer bed, the physiatrist, for example. And so it's going to be challenging, and we need to know more about it. And scientists are looking at it to see if there will be a blood test we can do, for example, but it's going to be a big problem.
There was a question about someone asking, saying, do you think the COVID might also cause reinfection, what's the word I want, coming back again, of maybe your Epstein-Barr virus surfacing up again, could be some other virus that might surface, just like HIV. When you get it, all the CMV comes up, you got all the weird infections that you never see on, let's say, an immunocompetent person. That's one anyway. Number two, you were mentioning about AstraZeneca and mixed vax, what they call COVAX or COMVAX. And I see a lot of people in London here, colleagues of mine, are getting 2 different shots, and they seem to have good antibody response. In fact, one of my patient in Nassau, when he's staying in England for a long time, I say, get your vaccination and then get your COVID test. Now, are you doing the I was mentioning the MAB, I saw the other day, something about COVID antibody, doing the quantitative one. Is that being done a lot in Nassau or not?
Okay, so a couple questions there. Yes, it's okay to mix vaccines. The immune response might be even bigger. COVID, it's new, but it is already making certain infections come to light, like mucormycosis is happening as a sequelae of COVID, especially in India. They had reported that. I don't know if it could cause EBV to flare, but at least one patient who has chronic EBV told me that they feel horrible again after getting COVID, and they were okay before that happened. So at least that's one anecdotal report, but I haven't heard a lot of other experiences with that, and I haven't seen it in the literature. And then the antibody levels. Now, antibody levels are not diagnostic in any kind of capacity. You should never tell a patient, let's see if you had COVID and do an antibody level to see if you need to be vaccinated. It's wrong. So antibody levels, they may have a role for surveillance, serosurveillance, for example. But we have to remember too that it's a very research specific thing. And even when antibody levels are measured, immunity is more than just the antibody level. There's a T and B cell response and memory B cells. And so I don't encourage in clinical practice antibody levels.
And so I want to thank you for making it seem so interesting for us tonight, and for speaking to us once again. And please do come again.